Sharing, I think Dr. Harini will be sharing, madam. So the sharing rights already given to her, no? Harini, you have the sharing this one, no? Just
Yes, sir.
confirm. Yeah, sure.
Please start.
Okay. So good evening, one and all. Welcome to the 6th edition of ESI Case Capsule. Today we are very fortunate to have Dr. Ganesh, Professor of Endocrinology, AJ Institute of Medical Sciences, Bangalore, to teach us about Cushing syndrome, and the case is being presented by Dr. Harini, the PG resident in the same institute. We have 5 brilliant doctors who have joined us, panelists, Dr. Brishdev from Bhubaneswar, Dr. Rebecca and Dr. Patmavati from CMC Vellore, Dr. Pratyusha from Hyderabad Care Hospital, Hyderabad, and Dr. Hedashvi from Narayana Hridayalaya, Bangalore. So from all over India, we have representation today. So without much ado, I would request Dr. Ganesh to take over the mic.
Good evening, madam. At the outset, I would like to thank Endocrine Society of India, the Dr. Jabbar sir, Dr. Nisha Bhavani madam, Dr. Nitin Kapoor, and the whole team for giving us the opportunity. Today, the case discussion is on Cushing syndrome. It's a great idea to have the discussions because just before going to the exams, it can be a ready reckoner for all the DM trainees. So it's a very great idea. Today, without much ado, we'll go to the case discussion straight. Over to Harini. Start your case.
Thank you, sir. Good evening, all. So I'm going to be presenting the case now. So here we have a 29-year-old lady. She is a resident of Suratkal, married, 6 months postpartum, lactating at present, newly diagnosed hypertensive since 1.5 months on medication. So she came to us in the OPD with chief complaints of excessive weight gain since 1 year, increase and change in the color of stretch marks since 5 months, difficulty in getting up from squatting and sitting position since 4.5 months. So these were her chief complaints. Now, to just elaborate, when we asked about the weight gain, this has been a progressive excessive weight gain since 1 year. Despite active measures, she was not losing the weight postpartum. Her baseline pre-pregnancy weight was 54 kgs, postpartum weight of 86 kgs, and the total weight gain in this pregnancy was about 32 kgs. In the 3rd trimester alone, she had gained about 16 kgs. She says she currently weighs about 97 kgs, and the weight gain is predominantly around the abdomen and upper back. She describes that there has been a change in her facial expression with more rounding of face. There has been new onset, increase and change in the color of stretch marks over the abdomen and upper aspect of bilateral arms since 5 months. There has been a gradual increase in the number of stretch marks and the width of the stretch marks. She noticed it that the stretch marks were predominantly over the abdomen and the upper aspect of bilateral arms. The previous stretch marks that she had, she noticed that there was a color change from a whitish transparent to a more dark pink violaceous color in the old stretch marks. She gives us history that she has difficulty in getting up from sitting and squatting position since 4.5 months. This was insidious in onset, gradually progressive. The patient initially experienced difficulty in getting up from a chair, and over a period of time, she noticed that she had difficulty in getting up from the squatting position in the washroom. This was not associated with any slippage of chappals with awareness, wasting, fasciculation, spasticity, sensory loss, incoordination, bladder, or bowel movement.
Harini, at this juncture, what is your thoughts? What is going on in your mind that this 6 months postpartum, significant weight gain and some stray and some degree of difficulty in getting up from squatting position. What are the things going on in your mind?
Yes, sir. So without a bias, I'd like to say that I can spot 2 discriminatory signs of Cushing syndrome. One being that probably with the symptom of difficulty in getting up from squatting and sitting position since 4.5 months, indicative of a proximal myopathy kind of a picture. And when she says that there has been an increase and change in the color of stretch marks since about 5 months, she's noticed that the color change has happened from a white, more healed stretch mark to a dark pink violaceous. So these things indicate towards Cushing's, I would say.
Suppose these stretch marks they are not there, or a discriminatory feature like proximal myopathy is not there. What is more common in this setting, like 6 months postpartum, the patient coming with excessive weight gain? So, what will be the thing? Bridge, can you tell what are the things you should think of at this point of time? So let us say let us assume the patient is not having this changing color of stretch marks, or the proximal myopathy features are not there. So what will be the differential diagnosis at this stage?
Can consider, sir, one is hypothyroidism, sir.
Good.
Secondly, sir, maybe postpartum certain amount of water retention. Those we cannot elicit at this point, sir.
Correct. So the Cushing syndrome is, since it's a rare disease, we can't screen each and every patient with weight gain for Cushing syndrome. Rebecca, can you tell us what are the Endocrine Society guidelines regarding in like OPD, busy OPD? Which set of patients you will be screening for Cushing syndrome?
So ideally, we would be screening for those with discriminatory features of Cushing's, which include proximal myopathy, easy bruisability, facial plethora, and yes, sir.
Anything else? Anything else you want to add upon, Padmavati?
New onset striae.
White purplish striae.
Right.
So
Young onset hypertension, uncontrolled diabetes.
Patients who are young with hypertension, osteoporosis, when there are progressive multiple features which are more predictive of Cushing's, for example, easy bruisability, facial plethora, proximal weakness, myopathy, and striae. If they're children, then if we're noticing that the height percentile gain is not as much compared to their weight, and in patients who are having adrenal incidentalomas, which could probably be adenomas, these would be the 4 as per Endocrine Society of guidelines for whom we need to screen for Cushing's.
Okay. Go ahead with the case. Yeah.
So, so just to give a picture to everybody, this was on the left side. We can see an image of the patient. She shares with me that this is in the past. This is previously. She just wanted to show like how the evolution has happened. And on the right, we can see this is how she had come to us in the OPD.
Yes, go ahead. So now it becomes a little more obvious. The facial features are also suggestive of Cushing. So probably next, go ahead with the history.
Yes, sir. So on further inquiry, so she also gives us history of amenorrhea since 6 months. She mentions that then there is darkening of there's presence of darkening of skin. There's presence of acne since 5 months. There is history of excessive unwanted hair growth over her face and her abdomen. She gives us history that she has been noticing generalized weakness and easy fatigability and since 4.5 months, along with headache.
Yeah. Hold on, Harini. Yeah.
Yes, sir.
So I would like to ask Hitashvi, what is the effect of cortisol excess on reproductive system or menstrual cycle?
So, sir, excess hypercortisolism is known to suppress the GnRH axis. Through GnRH, there will be suppression of gonadotropins, which will present as amenorrhea. And the other thing will be the presentation of hirsutism and acne, which occurs in view of if there is a pituitary cause of Cushing's, then ACTH drive will increase production of adrenal androgens, which will present as acne and excessive hair growth.
Okay, so yeah, when there is mild cortisol excess, there will be oligomenorrhea. Mainly there will be PCOS-like picture, and when there is severe cortisol excess, it will suppress the GnRH axis, and there will be amenorrhea. So, is there any difference in acne between like the pure cortisol excess or cortisol plus androgen axis, Padmavati?
So in patients who are having both cortisol and androgen excess, we would expect a more nodular acne or more pustular acne, sir, and also increased sebaceous because of the overproduction of the sebum. and also increased oiliness over the face will be more common in patients who are having both cortisol plus androgen excess.
What about only cortisol excess? What kind of acne you will get?
You would get papular. Yeah.
Papular, sir?
Okay. So the hirsutism, is there any difference between like only cortisol excess? Suppose let us say only the cortisol excess is there, no much secretion of androgens, then will there be any difference in hirsutism?
Yes, sir. Patients who are having only cortisol excess will have more prone for villous hair that will be excess. In patients who are having both cortisol and androgen, we would expect terminal hair growth to be more. So that they present more with hirsutism.
Good. So, what is the cause of hyperpigmentation in patients with Cushing's disease or ACTH-dependent Cushing's disease? Rebecca, what is the cause of hyperpigmentation?
So it's because of the action of there are two causes. One is because of the action on the melanocortin receptors, sir, which are present. And the second is because of the increased POMC that is being produced, sir, which also increases the MSH.
Okay, good. So go ahead, Harini, next.
Yes, sir. So the other symptoms that she had given us was reddish brown scaly patches underneath the breast and the inner aspect of the thigh, which was associated with itching since 3 months, along with irritability and mood swings. She also gives us history of easy bruisability on accidental minor trauma, and she was recently diagnosed with hypertension since 1.5 months. These were the other symptoms that she had given us on further inquiry.
So what is the cause of easy bruisability in case of Cushing's bridge?
Sir, first is cuticular atrophy of the skin, and additionally there is a increase in the clotting factor, that is the 1 milligram factor, the rate, and the
That will cause more
bleeding.
of thrombosis, no? Bridge, that will cause more of thrombosis. The bleeding will not be, or the bruisability will not be more because of the clotting factors. So that will be because of the
certain atrophy of the certain corneum, sir.
Yeah. So next.
Yes.
Yeah, go ahead.
Yes, sir. So just to expand upon, so she's been having amenorrhea since 6 months. She's P2L2. Her firstborn is an elder son, 4 years of age. Secondborn is a younger daughter, now 6 months. Patient has no menstrual flow post-delivery. She's lactating at present. She gives us history of darkening of skin since 5 months, which is incidence in onset, gradually progressing, diffuse. It is predominantly over the face, abdomen, thigh, upper back, around the neck, and the knuckles of bilateral hand. She specifically mentions that there is darkening of her lower segment cesarean section scar. There is acne since 5 months, pustules and papules over the facial skin around the cheek region. It is occasionally draining this whitish yellow fluid. She's been noticing that the breakouts have increased recently. She also gives us a history of headaches since 4.5 months. It's diffuse, holocranial, continuous, and dull aching. There's no diurnal variation. It was not associated with any visual complaints, and there have been no aggravating or relieving factors. She says that she experiences easy fatigability while doing day-to-day activities since last 4.5 months. Excessive unwanted hair growth since 4.5 months. Noticed it while recently seeing herself in the mirror, predominantly over the upper lips, cheeks, and downy sideburns. Later, she also noticed the same in between her chest while she's breastfeeding. There has been no recent history of any associated drug usage, any cosmetic procedure she underwent, or previous such symptoms or family history of the same. Reddish brown scaly patches underneath both her breasts and around the inner aspect of the thigh that was associated with itching since 3 months. Irritability and mood swings. She says that there are very alternating episodes of feeling very happy and then very sad. She's not experienced this previously. A lot of anger bursts and easy bruisability since 1.5 months. With accidental minor trauma, she develops bruises over the forearm and the shin of tibia. Hypertension since 1.5 months. This was picked up by her gynecologist on a routine checkup where the reading was found to be 160 by 90 mmHg. And so she was started on tablet amlodipine 5 mg once in the morning after food, and she's continuing to take the same regularly.
Yeah, next slide.
Yes.
Go ahead.
So on inquiry, there is no history suggestive of exogenous steroid intake, alternative medical system usage, any drugs. There's no history suggestive of dry skin, constipation, cold intolerance. No previous history of hirsutism, acne, menstrual disturbances, hyperpigmentation, weight gain, no history suggested of psychiatric illness or any medication for the same. There is no history of nausea, vomiting, seizures, visual complaints, or diplopia. No deepening of voice or balding or reduction in the size of breast. There's no history of
Hold on.
polyuria
Suppose if there is deepening of voice, balding, or reduction in size of the breast, what are the possibilities? Suppose that history is there in this
Yes, sir.
patient.
Yes, sir.
What is the possibility, Harini?
Sir, deepening of voice, balding, and reduction in size of breast would indicate towards signs of virilization, sir.
Yeah. So what will you expect in this kind of setting with the weight gain, proximal myopathy, and the Cushingoid striae, with all these, with the virilization features there, what do you think?
So it helps us to differentiate among the different types of Cushing's.
So what is the most likely possibility in that scenario? Anybody else?
Renal
It may be a
Cortical
possibility,
carcinoma,
sir.
sir.
This
Ectopic.
Adrenocortical
Co-secreting
carcinoma, will there be
Co-secreting
weight gain or weight
adenoma.
loss?
Weight loss.
Weight
Sir,
loss.
co-secreting adenoma is a possibility.
Okay. So the virilizing adrenal adenoma is one of the things what you have to think first. Okay. Next. Go ahead.
Yes, sir. So there was no history suggestive of polyuria, polydipsia, no history suggestive of any enlargement of hands, feet, loss of or increased libido, or coarseness in the facial features. No history of cough, hemoptysis, chest pain, palpitations, excessive sweating, and tremors. No history of diarrhea, neck swelling, flushing, and wheezing episodes. She does not give any history.
Suppose if there is this cough hemoptysis is there, or some flushing episodes are there, so what will be the possibilities, Rebecca?
So we would consider ectopic Cushing's like possibility of a carcinoid that is causing the same, sir.
Okay. Is small cell carcinoma of the lung is possible?
Yes, sir.
There will be weight gain or weight loss.
With weight loss, sir, usually.
So in this setting, very unlikely to be a small cell CA. So the carcinoid is still possible.
Carcinoid is likely.
Small cell carcinoma.
Yeah, but the history is not there. Yeah, if it is there, we have to think of carcinoid. Yeah. Go ahead, Harini.
Also, sir, there was no history of any fractures or height loss. There was no history of any backache, rib pain, no history of renal calculi, hypoglycemia, or PPI dependence.
Yeah, next.
So past history, we don't have any significant past history of DM, thyroid disease, any conditions such as TB, joint pains, asthma, skin conditions or swellings, or taking any medications for the same. No history of any psychiatric illness or any medication, no history of taking any medication for the same.
Fine.
No surgery, no hospitalization. And she just says that she took iron and multivitamin supplementation during pregnancy.
Okay.
She's born of non-consanguineous marriage. Her mother passed away because of complications arising from postpartum hemorrhage. There's no significant family history, sir.
Okay.
Personal history.
Nothing significant, no? Personal history, anything significant is there?
Yes, sir. Currently, amenorrhea. And the one part that I wanted to emphasize on is that prior to pregnancy, her periods were regular and lasted for about 3 days with 2 to 3 pad changes per day. And she's having 2 children, lower second cesarean section in both, breastfed both. Her sleep is reduced, sir. And there is no history of any alcohol usage or tobacco chewing or smoking. So those are the significant points. So I'd like to summarize now at the end of history, sir. So this is a 29-year-old married lady, resident of Suratkal, 6 months postpartum, lactating at present, recently diagnosed hypertensive since 1.5 months on medication. She presented with progressive excessive weight gain with predominant swelling of abdomen, face since 1 year, hyperpigmentation since 5 months, headache, fatigue since 4.5 months, striae since 5 months, easy bruising, proximal muscle weakness, with features of androgen excess in the form of hirsutism, acne, amenorrhea with cutaneous fungal infection, and mood disturbance. She denies exogenous steroid intake, and there is no significant personal, family, or past history. So this is the summary at the end of my history.
Okay. So what are the possibilities here?
Yes, sir. So at the end of our history, the possibilities that I had kept was that this could be very much likely Cushing syndrome, ACTH dependent was my first differential. The second is obesity, metabolic syndrome with PCOS. Third is hypothyroidism.
Yeah. So is it still obesity, metabolic syndrome, PCOS is still possible? So do you think it's still a differential diagnosis?
Sir, it would be less like in I kept it second. Less likely. It is a possibility, but less likely, sir, because for PCOS she has not had irregular periods in the past or any previous weight gain. It has just happened now, and
It
Okay.
will not,
Anybody?
they will not
Anybody?
have
and
Yeah.
such
obesity
discriminatory features, sir, which are there, for example,
Yes, sir.
striae or proximal myopathy and easy bruisability.
Yes. So very unlikely the ACTH depend. Why are you telling ACTH dependent?
Because of the strong history of darkening of skin that she gives us, and when she specifically mentioned that her lower segment cesarean scar had darkened from before, so I would say it's stage dependent because of the
Okay.
history of
Go ahead.
hyperpigmentation.
Go ahead. Go ahead. Examination part.
Yes, yes. So on general examination, patient is conscious, cooperative, oriented to time, place, and person. Her height was about 157.5 centimeters, weight of 97 kgs. Waist circumference is 108 centimeters, hip circumference was 122 centimeters. Waist to hip ratio was 0.89. The neck circumference was about 38 centimeters. Sir. BMI was about 39.1 kg per meter square. She belonged to class 2, basically. Blood pressure was 148 by 96 mmHg. She had taken her BP medications. So this was the general examination, sir.
Next.
This is our patient. General appearance, central obesity with thinning of limbs. There is a rounded appearance of moon face. Acne was present. Facial plethora is present. Hirsutism is present. Modified Feldman-Galloway score of 9 by 36.
Hold on, Arani. Hold on. What is the cause of the central obesity? Is very peculiar feature, a predominant feature of Cushing's. What is the cause, Padmavati? What is the cause of visceral obesity in Cushing's?
Yes, sir. So because there are more number of glucocorticoid receptors that is present in the visceral adipose tissue, that is one reason. Second is because the cortisol 11 beta hydroxysteroid dehydrogenase type 1 cortisol gets converted to cortisol. This is present more commonly over the visceral adipocytes. So these are the main reasons why there is central obesity compared to that of generalized obesity.
Is there any type of Cushing where you get generalized obesity in Cushing? Pratyusha, would you like to answer?
Yes, sir. So in childhood Cushing's, it's usually generalized obesity, sir.
Okay, when do you suspect Cushing's in a child?
So when there is the first sign usually will be growth failure, like the height disproportionate to the weight gain, and obesity and delayed puberty.
Okay, short
Cushing's can
obesity.
present with this.
Okay. Okay. Next, Harini, go ahead.
Yes. So supraclavicular fossa, there was a fullness which was noted. Clavicles are bilateral obscure. Dorsocervical pad of fat is present. Skin tags are present around the neck and the bilateral upper arms. Acanthosis nigricans is present. Bruise is present. Striae 1 to 2 centimeters in width. Broad, dark pink, present in the abdomen and bilateral upper arms. Hyperpigmentation is present, diffuse, predominantly over the face, abdomen, thighs, upper back, and around the neck. Knuckles of bilateral hands. Darkening of the lower segment cesarean section scar. Intertrigo is present underneath the breast. Head-to-toe examination was within normal range. On systemic examination was within normal range. I'd like to mention the confrontation test was normal. There was power of 4+ in bilateral lower lip. I checked the hip flexors.
So what is the cause of proximal myopathy in case of Cushing's bridge?
There is increased muscle catabolism, sir. That is one of the cause. Additionally, sir, there is a atrophy of the type 2 muscle fiber and hypertrophy of the and overall it is a catabolic state, sir. And other than that, sir,
any things other than that? Proximal myopathy causes?
Sir, hypokalemia caused by spillover of glucocorticoids on mineralocorticoid receptor can also cause myopathy.
Other metabolic disturbances like hypokalemia, hypomagnesemia, all can lead to proximal muscle weakness. Yeah.
There is a decrease in local IGF-1 production, sir, which in turn leads to increase in myostatin, as well as there is a decrease in the myogenin as well. This, along with the type 2 myocyte atrophy, leads to the proximal myopathy.
Correct. Fatty infiltration of the muscles also happen. Yeah, true. So next, go ahead.
So the summary at the end of my examination with the history, the positive examination findings of moon face, dorsocervical pad of fat, striae, facial plethora, bruise, acanthosis nigricans, skin tags, intertrigo, hirsutism, diffuse pigmentation, and acne.
Okay. So what are the possibilities? Go ahead.
Yes, sir. So the possibilities at the end of my examination findings were this could be endogenous, ACTH-dependent Cushing's syndrome, query Cushing's disease.
So how do you differentiate clinically endogenous versus exogenous Cushing syndrome?
Sir, in pertaining to exogenous Cushing syndrome, there will be a strong history of drug intake. It would be one of the things. The second thing would be the features of hyperpigmentation, realization are less. There are some features which are much more predominant in an exogenous Cushing than endogenous
Like?
Cushing. For example, hypertension, hirsutism, these would not be noticed in an exogenous Cushing, whereas it would be seen in endogenous Cushing. And certain features, for example, cataract or pancreatitis, or if there is osteoporosis, those are more seen in exogenous Cushing's.
Okay. So,
And yeah.
okay. ACTH dependent. So already you have told us. So why are you telling it's probably Cushing disease? Why not ectopic?
So as per my history and examination, the factors that would go more positive for Cushing's disease is A, this is a female, two, the age group that we're looking at, and she does not have any symptoms of cough, hemoptysis. We ruled out those particular symptoms of suggest to ectopic ACTH, and yeah, these were the
So
reasons why I
the
thought of Cushing's disease.
gradual onset, no much metabolic features, probably endogenous Cushing's disease is very likely. So Rebecca, what is the first investigation you will order in this patient? First
So
investigation.
I would still do an 8 a.m. cortisol, sir, to rule out exogenous, because that is the most common cause of Cushing's.
Good. So suppose 8 a.m. cortisol comes 14 or 15. Yeah. Next.
So then I would
Yeah.
like to go ahead with the evaluation for Cushing syndrome. So we have to go ahead with 2 screening tests, sir. So the screening tests that we do are can be 24-hour urine-free cortisol. We do midnight salivary cortisol. We also we can do an ONDST, and if 2 of 3 tests are positive, then we confirm that it's a Cushing syndrome. In our institute, we also measure the midnight serum cortisol as well, sir. And we compare it with the 8 a.m. cortisol to see if the diurnal variation is lost.
Correct. So suppose let us say this particular lady was pregnant. In that scenario, what are the investigations you will order first? So I think in this question I'll ask to Hitashvi.
Sir, urinary free cortisol is the preferred investigation in case of pregnancy, where though it will be elevated mildly, but more elevation of more than 4 times upper limit of normal strongly goes in the favor of endogenous hypercortisolism.
So what is the cause of elevated cortisol in pregnancy? In a normal pregnancy, cortisol will be elevated. What is the reason?
Sir, there are few one of the reason is during pregnancy the cortisol binding globulins will be high, which will give us a high cortisol value on a laboratory analysis. Another reason is placenta does produce CRH, and because of that there is stimulation of there is increased ACTH production and cortisol production. As yeah, yes, sir.
So Padmavati, is there any, sorry, Pratyusha, I think I didn't ask her for quite some time now. So the Pratyusha, is there any trimester specific increase in cortisol levels? Is there anything like this much it will be elevated first trimester, second trimester, something like that?
I am not aware of it, sir.
Anybody can?
So 1.7 in the first trimester, second trimester would be 2.4 times, and the third trimester is 3.1.
So any times, as Hetashu mentioned, at least 4 times the upper limit should be to tell that there will be increase in cortisol levels. Okay. So, Bridge, what are the advantages of late night salivary cortisol?
Firstly, it will these are very sensitive test, sir. Secondly, we do not have to call the patient. It's just a simple visibility is there, sir. You can just select and the simple can be given, sir. Secondly, sir, it is a
I was not very much audible.
Also,
Can you repeat?
sir, for follow-up also, sir, late-night salivary cortisol, like is a post-operative use, if there is a recurrence, late-night salivary cortisol is one of the most sensitive early marker for detecting recurrence in an operated case of disease.
The collection becomes very easy. Then it measures free cortisol levels, and the venipuncture is not required. So even the late night, even that stress, venipuncture stress will not happen. So these are the advantages. So is there any cutoff which we use for late night salivary cortisol?
So, sir, usually cutoff we use is 145 mg per DL.
140. Okay. So
5
no.
mg per DL. Some books mention 2 mg per ml also as a cutoff, sir.
Okay. So what are the disadvantages, Rebecca? What are the disadvantages of late night salivary cortisol? Rebecca?
Yes, sir. So there's a strict protocol on how we should collect the late night salivary cortisol. So patients should have we need the salivate and we need the salivate readily available, sir. Firstly, second is that the patient should like if they have any gingivitis or any gum injury, then we can get falsely elevated salivary cortisol levels. Also, we should make sure that they have their dinner early before 9 o'clock, and also that they should brush their teeth if they're doing so before 9 o'clock, so that the values don't interfere with the salivary cortisol, because saliva also contains 11 beta HSD, which can cause a falsely elevated value. Presence of blood also into the collection tube can cause falsely high values, sir.
Is there any pregnancy specific cutoff for late night salivary cortisol? If suppose the woman is pregnant.
I'm not sure of the value, sir.
Padmavati,
No, sir,
Pratyush,
during
anybody?
pregnancy, the circadian rhythm is maintained physiologically. So, any elevated value, just like in normal patients, elevated value of late night salivary cortisol will be
No, but because of the whatever the placental CRH and sometimes ACTH secretion itself, the cortisol levels will be high. Even it may be slightly higher. So the even second and third trimester slightly higher value they mentioned 2.5 or 2.7 nanogram per ml they mentioned for late night salivary cortisol. So yeah, go ahead, Harini. Next, what did you do?
So we came to the investigations. So we had an ODS cortisol of 7.68 microgram per DL. We then went ahead with an LDDST cortisol, which gave us a value of 8.59. Midnight cortisol value of 12.2 microgram per DL. ACTH was 63.8. We had a free T4 value of 0.804 nanogram per DL. A fasting blood glucose value of 195. HbA1c was 5.8. Serum electrolytes were suggestive of sodium of 139, potassium of 4, and a chloride of 97. The other parameters.
Hold on. So the low dose dexamethasone suppression test. So it's like what are the drugs which you have to rule out before? I think I'll ask this to Pratyusha. So what are the drugs which can give rise to false positive LDDS cortisol high value?
Sir, drugs like false positive, sir. So false
Yeah.
positive is seen with phenobarbital, phenytoin, rifampicin, and then
Any anti-diabetic drug?
carbamazepine, pioglitazone, sir.
Okay. So any increase in CBG because of any of the patient is on estrogen?
Estrogen, yes, sir. Increase CP.
Yeah, false negative. Is it possible to get false negative, Padmavati?
Yes, sir.
Yes.
And drugs which is going to accelerate the metabolism of dexamethasone can cause false negative, like ritonavir.
No, accelerate the dexamethasone, that will give false positive.
Sorry,
Which will, so impairing dexamethasone metabolism, that will produce false negative because the dexamethasone level become higher. So that's the reason even some Cushing's disease can also get suppressed. So that's why, So which are the drugs which can produce false negative?
Sir, ritonavir, diltiazem.
Okay. Any antifungals?
Ketoconazole, itraconazole.
Suppose let us say this lady was on oral contraceptive pills. Can we do low dose dexamethasone suppression test?
No, sir.
No, sir.
So what if suppose you are keen on doing LDS? So then what will you advise her?
We should actually stop the oral contraceptive pills for at
6
least
weeks.
6 weeks and then do a low-dose dexamethasone suppression test.
Okay. Let us assume this as a pediatric patient. So, what will be the dose of dexamethasone in children, pediatric age group? So, LDDST, what will be the dosage?
So if
30
patient is less than
30
40
micrograms.
kgs, 15 microgram per kg for ODST and 30 microgram per kg for LDDST.
It's 30 microgram per kg per day or 30 microgram per kg per dose?
No, sir. Per day, total dose in divided.
30 microgram per kg per day in 4 divided doses. Okay.
4 divided doses.
Okay. So coming to ACTH, let ACTH is 63. So I think Bridge, do you want to comment? This patient, ACTH 63. What's your opinion?
But the LCTH of 63 is like first thing LCTH dependence is confirmed, sir. Still, I would like to keep the possibility of ectopic Cushing in mind, relatively on the higher side. Although it would have been more than 90, would have been clear cut. Still bit on the higher side, so I may still consider evaluating for ectopic parallel.
Okay. So what will be the next line of investigation? Rebecca, what's your next investigation after all these tests?
So after, based on this ACTH, I'm thinking in terms of ACTH dependent Cushing syndrome. So next would be an HD-DST, sir, to identify if there is a 50% suppressibility or not. And based on that, proceed further, sir.
So what is the sensitivity of HD-DST to for diagnosing Cushing's disease or ruling out ectopic? Sensitivity of the test, HD-DST?
The
Anybody?
sensitivity is around
60 to
90%, but however, the specificity of the test is lower, sir.
So how much?
Specificity is only around 70 to 80%.
Yeah, I think even lesser than that, 60%.
Yes,
So
sir.
the HDDST, the specificity is much lower. So the positive predictive value of like pre-test probability of having Cushing's disease is much higher than the specificity of the test. So that is the reason probably we can go ahead with MRI also. There are different schools of thought, but anyway. So Harini, next.
Yeah. So we went ahead with an MRI imaging. So MRI pituitary plane with contrast. The pituitary measures 16 into 9 into 10 mm with a convex upper border. The stalk was about 2.7 mm. A well-defined, non-enhancing, altered signal intensity lesion in the anterior pituitary on the left side, which is suggestive of pituitary microadenoma. Hypointense in T2 measuring 10 into 6.7 into 6.4 mm noted in the pituitary on the left side. The sella was widened. The optic chiasm was normal. The rest of the brain parenchyma was within the normal limits.
Okay.
Visual
So,
field analysis.
yeah. Vasanti, are you a
No,
PG?
no.
Sorry. That's why. So, Hedashvi, so what is the sensitivity of MRI
Sir, contrast
for
enhanced
diagnosing
MRI.
Cushing's disease? Yeah.
Yes, sir. It's a normal contrast enhanced MRI will have a sensitivity of around 57%. And when we do it as a dynamic sequencing, it increases to 69%. And if we again go ahead with spoil gradient imaging, it increases to even further, almost 80% sensitivity.
Okay. So, yeah, go ahead, Harini. So, here we have a lesion of a 10 millimeter into 6.7 into 6.4 millimeter. So, what next? So, Bridge, you want further investigations?
If the size would have been more than 10 mm, but around 6 mm, we must still consider this an IPS system.
Okay. So 10 mm, the IPSS is not a must. So usually, what is the size of the lesion you get in case of Cushing's disease? Rebecca, what is the usual size of lesion? Median size of a lesion?
So
Yeah.
it's microadenoma, sir. Around 6 mm, sir.
Okay. So is macroadenoma possible? How much is the prevalence of macroadenoma in Cushing's disease?
So around 10 to 20%.
Yeah. What is the reason? What exactly is the reason for some corticotropinomas becoming macroadenomas? Any explanation for that?
Sir, could
Anybody?
be kind of silent ACTH adenoma or Krug cell adenoma, which usually presents as biochemically they will have higher ACTH, but may not present as florid hypercortisolemia. And there will be a macroadenoma in the pituitary. One of them is Krug cell adenoma.
So, any other explanation? Any other explanation for the corticotrophy? Like just like acromegaly, it's becoming macroadenoma, so not producing enough symptoms to detect early. So, Pratyusha, any other possibility? Any other reason, explanation given?
So there can be a transformation of silent
The
corticotropes.
genetic predisposition, like usually if the adenoma.
So actually the altered, like the POMC, if it is not properly processed, so that can be like the ACTH production may not be sufficient, or sometimes the polymorphism in the POMC gene also can produce macroadenomas. Okay, next.
So these were the pre-surgical investigations and treatment that were offered to the patient.
Okay, go ahead.
Following a neurosurgical consultation, the patient underwent a transnasal transphemoral surgical resection of the pituitary microadenoma under GA with graft and repair. The intraoperative period was uneventful, so vitally hemodynamically stable with monitoring of vital fluid intake and urine output. Post-operative period was uneventful. There was no CSF leak, vitally and hemodynamically stable, and the fluid intake and output was charted, which is okay. The BP was 110 by 80 mmHg, and so we had we withheld the antihypertensives post-operative.
So how do you assess for post-operative remission of Cushing's post-operatively, Harini?
Sir, to assess the remission of Cushing's in the post-operative period, we'd like to obtain after 20 to 30 hours a cortisol value, to a baseline cortisol value to assess how the remission is. So if it is on the lower side, then we know that there is requirement of the group. Steroid replacement would be
So
required.
what value you take it as remission? Which value of cortisol, 8 AM cortisol you take as remission?
2, less than 2. I mean 5.
So like you will not be starting any steroids post-operatively, or you will be starting steroids and stopping for some time and seeing. So how will you do? So Rebecca, how will you? Bridge wants to answer. Bridge.
So, sir, if the cortisol post-operative and day 1 to 70 cortisol is less than 3.6, we may consider putting on cortisol in replacement. If it is more than 12.6, we may decide not to go for replacement.
No. Bridge. My question is, intraop and perioperative period, you want to replace or supplement hydrocortisone and then stop off some time and test for cortisol, or you don't give any steroid supplementation immediate post-operative period and test for cortisol levels?
Sir, it's preferable to give supplementation for post-operative.
Rebecca?
So if it's a transsphenoidal surgery, that is a TNTS that is performed, ideally we do a post-op cortisol at the 8th hour post-surgery, and then subsequently on post-op day 1, 2, and 3. We do not give hydrocortisone or steroid until we ensure that the patient has complete remission.
So absolutely. So I think the patient is floridly Cushingoid. So very high cortisol levels. The patient may develop steroid withdrawal symptoms, and the patient might go into hypotension. So you have to be careful. So you will have to supplement hydrocortisone. If the patient is mild to moderate Cushingoid features and not much features, probably you need not start hydrocortisone supplementation immediately. You confirm the diagnosis of either remission or persistence, then you can go for supplementation. Okay, go ahead, Aaron.
Yes, so so this is our post-operative analysis chart. So for this particular patient, on day 2, we noticed that vitally she was stable. BP was about 110 by 70. The output intake was about 1,500 ml. Output was 1,000. The serum cortisol obtained was about 1.5 microgram per TL. So we had initiated on hydrocort 50 mg IV TID.
Okay,
Continued
I would like
hydration.
to stop here. I would like to ask Pratyusha. So how will
Yes.
the patients feel immediately after surgery, after day one after surgery? How will be the patients feeling? What will be their, when you go for rounds, what will be their response to you? How will they feel? Pratyush, are you there?
Yes, sir. Like in patients like who are on hydrocortisone replacement, steroid withdrawal symptoms might not, glucocorticoid withdrawal symptoms might not be present, sir, but there will be some relief of edema, and as in the decrease in the fluid retention, and
Yeah,
as in
reduction in swelling. So they'll
yes,
tell
sir.
the soft tissue swelling has come down. That is their.
Soft tissue swelling has come down.
And sometimes, they might feel worsen symptoms might get worsen also. Joint pains and all those things can, just like glucocorticoid withdrawal syndrome, can happen post-operatively. So we have to watch for it. Okay, Harini, continue briefly.
Yes.
Continue briefly.
Yes, sir. Yes, sir. Sir, on post-op day 3, we had stopped hydrocortisone, overlapped with tablet prednisone 5 mg 3 times a day. Everything seemed to be fine. Post-op day 5, the serum free T4 was done 1.02 nanogram per dl. And on discharge, we planned for prednisone 5 mg BD, and we had given her calcium supplementation and vitamin D supplementations.
Okay, next.
Yes, sir.
Yeah, go ahead.
So we also received the histopathology specimen. So this was suggestive of a corticotroph adenoma, cella,
Yeah.
TPIT positive, ACTH was positive in the tumor cells.
Okay. Go ahead. Next.
So now we come to the follow-up, sir. So the patient came back to us at about 15 days, and she said that her weakness had subsided, the generalized weakness has subsided, her irritability has reduced, hemodynamically, vitally, she was stable. She was about now weighing 96.5 kgs, electrolytes were within normal limits. She was on prednisone, and then she came back to us in a month's time. At that point of time, there was a weight loss. She was weighing about 92 kgs. She says that she came back very happy, saying her periods have started again, and stry had reduced and color had
Forgot
changed.
to ask, what are the immediate post-operative complications you expect? Padmavati?
Yes, sir.
Immediate.
In patients who have undergone transnasal, or even patients, if it was a macroadenoma and if they've undergone a transcranial procedure, one is the electrolyte disturbance, the triple phase response which can be seen, sir, where the first phase it can be a central diabetes insipidus, second phase with SIADH, and a third phase again with a diabetes insipidus. Second is the post-operative infections, because she's a lady with Cushing, she is more prone for infections. So post-operative infections. Third is an immediate CSF leak, CSF rhinorrhea that can happen. And fourth is the meningitis, post-operative meningitis. And because she's a lady with Cushing's, even more prone for deep vein thrombosis and pulmonary embolism.
Okay. So how do you assess for, Rebecca, how do you assess for the recurrence? So which is the best test to assess recurrence?
Salivary cortisol also.
Okay. So what is desmopressin test? So Rebecca, desmopressin test?
Not sure, sir.
The desmopressin test is it's an analog of vasopressin V2. It's basically using the principle is using that the V2 receptor expression is more in the Cushing's case. So we give about 10 micrograms of desmopressin, and we will be checking the ACTH and cortisol at 15 minutes, after 1 hour, 2 hours, in 15 minutes, 30 minutes, 45 minutes, 1 hour, 2 hours, to check the ACTH and the cortisol value.
Okay. So that will be the earliest.
18% increase in cortisol and more than 36% increase in ACTH value from the baseline. And that is strongly suggestive of.
Said that it is the desmopressin test is earliest to go wrong in recurrence of Cushing's disease. So let us assume that patient has come with the recurrence. So what are the options? Bridge. So she has come with the recurrence.
Sir, a repeat surgery may be an option, but medical management will be then strongly considered in cases of recurrence.
Why were you going for medical management? Which medical management?
So we can use ketoconazole, we can use nitrodent, we can use desidotide, we can use methyrophone.
Medical management. Will you give lifelong medical management for her with if it is recurrence?
We'll have to follow up and monitor, sir.
Sir, usually when we establish recurrence, which as you say, desmopressin test is the first to go get deranged in case of recurrence, we may not always be able to pick up an adenoma on imaging. So till you, I mean, if you are not able to pick up an adenoma for that period of time, we can go ahead with medical management and keep them on a close follow-up. Or other option could be go ahead with IPSS, establish the lateralization of the adenoma, and then go ahead with whatever the hemihypophysic the available.
Hitachi, let us say, assume there is an adenoma, pituitary microadenoma, 6 millimeters still there now. So, what are the options?
So she was already operated previously. So basically, Cushing's they undergo hemihypophysectomy. So now, if you tell me that there is an adenoma that is likely to be in the remaining part of the gland, then we will go ahead with the hypophysectomy. The remaining part of the pituitary will go ahead with the surgery.
Why? Since she has finished her family, why can't we think of radiosurgery?
Yes, sir, that's what I'm saying. We can go ahead with the surgery.
Not surgery. Gamma knife, radiotherapy, why can't we consider?
Yes.
So, because since there is a clear-cut adenoma, if you are knocking out the other half of the pituitary, you are rendering her into hypopituitarism. So, if radiosurgery can knock out the only adenomatous tissue, precise localization, if it is possible, probably that will be a better option. Since already she has completed her family, that will not be a problem anyway. So, anything else to discuss? So, if not, we have almost touched upon the diagnosis, investigations, and management. So, I'll hand over the session to the organizers. Thank you. Thank you for the opportunity.
Thank you, Dr. Ganesh, for that excellent discussion. Thank you, Dr. Harini, for that wonderful case and the pictures, which were very, you feel very happy seeing the lady at the end. Thank you, participants, for the wonderful discussion. Now, over to Dr. Nitin for the quiz.
Thank you, ma'am. And thank you, Dr. Ganesh, again for that very, very illuminating, I would say, a crash course on Cushing's for anybody going for exam. Within 40 minutes, probably they will know everything, almost everything that they need to. But thank you again for taking out the time. And thank you all students for joining. So now we move on to the quiz that we have. I'm sure that most of you have already taken part in this quiz so far. And there is a cash prize to this quiz of 10,000 rupees. For the top one winner who will get not only the maximum answers correct, but also will know that they play really fast. So it's the fastest fingers first. And though I know most of you are already aware of the rules, I will just take you through the rules once again. And what you need for this quiz is just another smart device in addition to the screen that you're watching this particular Zoom platform through the ESI website. You need good internet and obviously you need good brains to answer fast and correct. So you would get a maximum of 1,000 points for each correct answer. There is no negative marking. All are multiple choice questions, and you would be able to join the quiz soon after we show you the barcode. So I will move on to the next slide, but I think that will take one more minute before I do that. But till then, what I'd really like to say is that many of the answers have been discussed today. So if you've been listening carefully, definitely you would be able to answer a lot of questions. There are in total 10 questions that we have today, and each question would be 1,000 points. If you by any chance get logged out during the quiz at any time point, then you can join back based on the barcode number that is available on each of the slides that you would be seeing. So yes, I think with this I've got the barcode in place, and you could see the barcode. All of you should be able to join the quiz now through this barcode. when I move on to the first question, you'll be able to enter your name. I request all of you to enter your correct name so that you should be able to get the prize if you win. At this point, you should just see a green arrow on your screen, which should say you're all set and waiting for the presenter. I already see 23 people with a thumbs up, so I know that a lot of people have joined and this number has jumped to 32. So that's great. So I think it's time to move on to the next slide and we'll be starting the quiz now. Please enter your name correctly. So we have 73 people. Let's get started. Most of you have got it right, yes. The skin manifestations are indeed the most common, seen in about 80% of patients with Carney's complex. And though this was a Cushing session, it's not the nodular hyperplasia or pituitary lesions which are the most common. Dr. Aditya Daga is leading right now. Fairly simple question. Tricky question. The answer is McCune right. Right, so you can see this is a table from Williams, and definitely McCune Albright is classified as ACTH independent. So Ankit Chhabra is reading right now, but the others should not lose hope. Move on to the third question. So the small cell lung carcinoma is common, but the non-small cell lung carcinoma is not uncommon. So that was the trick here. Different series do refer to different prevalence or incidence of which tumors are common. But amongst the four that were given, the pancreatic carcinoids are reported to be the most common. So yes, small cell carcinoma is common, but the non-small cell is not the common one. So Gladdy is leading. Glad most of you got it correct. Again, table from Williams, very clearly there's a decrease in TSH, TBG, and TTTR, but yes, there's an increase in the RT3 production. We've had a different winner for almost every round, so nobody should lose hope. Glad most of you got it right. This is again from Williams. There is definitely inhibition of the monocyte differentiation, and that's one of the mechanisms how there is the impact of glucocorticoids on the immune system. Gladdy is back on top again. Well done. Glad most of you have answered correctly, but we have answers all over the space. You have to know about USP8 mutant corticotrophic tumors, which are well identified even in India. Ravi Shah is leading now. Good. Most of you got it right. Ravi Shah is leading still. We have 3 more questions to go. Yes, oxalotocin is one of the highest efficacious drugs. That clinches the answer here. Dr. Ravi Shah is still leading. We have 2 more questions. The options will be bigger on your screen on the phone. all of you manage patients really know you have to stop this thromboprophylaxis. Ravisha is still leading. This we move on to the last question of the quiz today. Again, majority have got it right. Let's see who's the winner of the quiz. So as you can see, it depends who is fast and correct most of the times, and the answer can change. The quiz winner can change very significantly at any given time point. So I would request Dr. Nanda to please contact me. Just send a WhatsApp to me and I'll make sure the money reaches you. And congratulations to you, and well done, everyone. And again, thank you all for joining today. And thank you again, Dr. Ganesh, for that very illuminating crash course in Cushing's, if I may call that. And this will all be available at the ESI website as a ready lecture anytime, forever on YouTube as well. So with this, I may request Dr. Nisha ma'am to say the final concluding remark, and then we'll see you.
Thank you very much, Dr. Nitin, Dr. Ganesh, and all participants for the wonderful 1 hour we had. So till we meet again on August 28th with another session of ESI case capsule, it's good night from all of us here. Thank you.
Thank you. Good night. Thank you.
Thank you,
Good night,
ma'am.
Nitin. Good
Thank
night.
you, sir.
Good night,
Thank you.
ma'am.
Bye-bye. Bye. Bye.